Good afternoon, everyone. This is episode six of a podcast of prostate cancer, prostate disease. I'm here with our associate editor, Tim Daskivich, who will talk us about a little bit of treatment consultations. It's a pretty tricky argument, so most of us spend a lot of time doing such activities, and probably most of us are not doing it well. So probably Tim will enlighten us a little bit more on this subject. So can you please tell us where you work and what you do in your hospital, please?
Yeah, thanks. Thanks so much for the invitation, and so happy to talk about this topic today. I'm a assistant professor of urology at Cedars-Sinai Medical Center in Los Angeles. I'm also the director of academic urologic oncology there for the faculty. And that's the article that I'm going to talk about today looks at variation in how side effects are communicated to patients in prostate cancer consultations.
And so what was the input for this research?
So the impetus for the research, the reason why we did it?
Yeah, because it's a different argument. It's not metastatic prostate cancer. It's more patient-centered. So
it is. So, the reason that we did this paper and that I specifically am interested in this topic is my whole career has been devoted to understanding why patients get overtreated for prostate cancer, not just due to their cancer risk being low. We're all familiar with that due to the active surveillance era, but also why patients with limited longevity end up getting overtreated. And my hypothesis going in is that we're not communicating information well to patients. So we actually published an article in Journal of Urology in August 2022, looking at how prognosis was communicated to patients.
Mm-hmm.
And this is the companion paper that looks at how side effects are communicated. And what was interesting is we told physicians that we were recording them. We told them that we were going to record their consultations and look at the way that they communicated risks. And we digitally recorded 50 consultations. And these were for clinically localized prostate cancer. Mm-hmm. And it was across a multidisciplinary sample of urologists, radiation oncologists, and medical oncologists, because these are the doctors that typically counsel men with newly diagnosed prostate cancer. And what we found is that there's tremendous variation in the level of detail of information that's given to patients from a consult to consult basis. And it differs a little bit by specialty, differs a little bit by clinical scenario, but even within categories of specialty and tumor risk, we saw that communication was highly heterogeneous, and happy to elaborate further on the details here.
So, but tell us a little bit, but in your opinion, which are the side effects, especially let's say for radical prostatectomy, that may be omitted from the patient? Because when you go through the leaflets, normally they are all normally categorized by frequency. But what do you believe you may omit? Because there is even a small risk. There is a small risk of dying of surgery. So normally we don't say it because it's scary. So which one do you think may be omitted, and which one do you think that normally, based on your results, that you normally clinicians omit and they shouldn't?
Right. Yeah, there's guidelines on this. It doesn't just represent my own opinion. So the AUA guidelines for shared decision-making in prostate cancer recommend that you communicate risks, detail the risks in terms of quantification of the major risks of the treatment options that patients are interested in. So, basically what we found, I'll summarize what we found, and then I can contextualize what I think we can omit or what we should say. So we basically looked at among these 50 consultations, and among the consultations discussing surgery, so that was 40 out of the 50 consultations where surgery was just mentioned. Using that as a denominator, major side effects like erectile dysfunction, urinary incontinence were omitted in roughly 10 to 15% of cases. They weren't quantified in about 30 to 40% of cases. And they were quantified and given a timeline in roughly 30 to 40% of cases. So, and for post-radiation side effects, the major side effects like irritative lower urinary tract symptoms, ED, and other kind of more rare side effects like secondary malignancy and bladder and bowel bleeding, those were omitted between for irritative urinary symptoms about 22% of the time, ED 42% of the time, and other, I guess, rarer side effects were omitted about 60 to 70% of the time. So I think one can use their own lens to determine what's appropriate based on guidelines and that those degrees of omission. You know, as a urologist, I can't imagine discussing surgery without at least mentioning urinary incontinence and erectile dysfunction. Now, whether I go into deep detail about recovery, pad usage, and the percentages of people continent, pad-free at a year might depend on, you know, the clinical circumstance, but I would at least mention those side effects. And ideally give them some quantification. And then for radiation, I mean, I'm not a radiation oncologist, but I would imagine when I'm discussing radiation therapies, to give patients some degree of the amount of risk they're getting into, I would at least want to articulate the names of the side effects and at least give some rough estimation of their likelihood. Your initial question was, what side effects can we omit? Is there some sort of threshold for frequency where you can just omit it? And I'm not sure I know the answer to that question, but my opinion would be that, you know, if a side effect is like less than 1% risk, probably don't need to articulate that risk too much unless it's a huge risk event. You know, should we be telling patients about risk of death with prostatectomy? Probably should. Just tell them the risk is, you know, exceedingly low, like, 1 in 1,000 cases. The problem is if you don't articulate these risks, your perception of what is quote unquote low may not be the same thing what a patient considers to be low. So to give them some frame of context, you have to at least mention the name and give it some sort of quantification.
You know, I completely agree with you because I really think that there are different thresholds depending on people, meaning that probably in everyday life, people want to risk or not to risk, even in normal activities, right? So another thing that I would like to know is normally in your consultations, how much time do you spend explaining the risk of rectal prostatectomy? What is a normal time?
Yeah, so we actually looked at this in a separate project. We actually looked at these 50 consultations and we labeled every sentence in the consultation with some sort of thematic content. And it turns out that urologists discuss their treatments, including like the details of how it's done, the anatomy, and the side effects with about half of the consultation. So in a typical 40-minute consultation, you might spend 20 minutes discussing the, you know, how the surgery's done, typical recovery, and side effects. So the majority of the consultation is actually spent discussing side effects and, you know, risks and rewards of these therapies. The other time is spent shared decision-making, educating the patient about what prostate cancer is, their overall prognosis, and then ideally, you know, eliciting their preferences and values and coming to an agreement on what to do next. But yeah, I typically spend, I would say 10 to 15 minutes of a discussion talking to them about the risks of therapy. The other point would be that most patients decide between treatments based on the side effect profile. So it's kind of the key information they need to make a good choice.
Okay, and meaning what's the best time to explain all of this? Meaning the time, meaning is it like the day you're giving the indication or the histological report?
Yeah, it's a great question. I think different doctors do this differently. Even my partners at Cedars-Sinai, we all do this differently. The way that I do it, I will frequently do the biopsies for these patients and would deliver that in the results of the biopsy a couple days later when the path results are available. And I usually do that over the phone quickly, and I give them a high-level overview of the different options. And then I schedule another visit that I can take a half hour or however long it takes to go through the different options in detail with the patient at a later visit. Some doctors may give them the path information and then do the treatment consultation right at that time. But when is the right time to talk about risks and rewards? I mean, it's whenever you're going to devote enough time to do that treatment consultation. And on average, those consultations last between, like, I would say 30, 40 minutes.
Okay, and so normally just before surgery, you go through it again. So do you do it in more steps? So you do like a refresh before surgery, or you?
I do. I actually, this is my area of research interest. So I spend a lot of time counseling patients. I take pride in it, and I think I do it well. But I do, at the time of treatment consultation, we go in depth in this. But then also right before surgery, I'll talk to them. And sometimes it may be a couple weeks since we've done the consultation. So briefly, I'll just go through the risks of the of surgery right before the case with them again, just at a high level. And that gives them an opportunity to ask questions that they may not have thought of during the consultation. Maybe they've thought those few weeks and had some questions. And I find that it doesn't make them more anxious about the surgery. It actually makes them less anxious because they feel like, again, they know what they're getting into and they have opportunity to ask questions.
Yeah, I completely agree. Another futuristic question for me, because I'm writing to such a topic, is that now we have just introduced ChatGPT into our everyday lives, and in other types of in different subjects, ChatGPT has been already, or chatbots have been introduced as help, like phone enterprises that they are able to answer the first question. So, do you think that a chatbot may be useful so that they can actually answer the normal questions? So, do you
Yeah.
think that may be useful, or you think that we may lose a little bit of human contact with the patient? I mean, I don't believe chatbot may be alone, but it may be useful because he may answer questions at any time.
Yeah. I think there's definitely use for chatbots. To give information is almost like an introduction that then can further be clarified by the doctor. If you look at, I mean, there's some data out there already looking at accuracy, meaningfulness, readability, um, level of sophistication of the information. And overall, depending on the engine, the chatbot, it's the information is reliable, but it's not always reliable. And I think the challenge in healthcare with implementing ChatGPT or other chatbots is you need it's a high stakes decision, and the information needs to be reliable and patient specific. So to me, the way that I look at it is, at least at this point, chatbots can be used to augment what the physician does, but it should not be used as a substitute. If you look at the information that ChatGPT gives on a given topic, it may go off on a tangent sometimes. Some of the information might not be fully applicable to the patient. And I think those inconsistencies might confuse patients. I think we're at a very early stage with those, though. I think in the future, it may be that, a patient talks to the chatbot and then goes in with the doctor, and the nature of the conversation with the doctor changes because they don't have to ask those other questions. They've already been answered by the chatbot.
A big step forward in this path, because I agree with you. I went through most of the guidelines with ChatGPT, and as you say, there initially ChatGPT is very wide, so it gives too much information. So, like when you ask him for TURP, he will go for incontinence right away. So maybe they will scare patients because it's not that frequent for such an intervention. But now the big advancements is that you can personalize your chat GPT and give a specific task. So you may, because the other thing is that probably each of us has its own way of being a doctor. So the big step forward is that you can just tell your own GPT what to say and what not to say by simple training. So I think that this will probably change the way GPT. So you can have your personal assistant as a chatbot. So he knows what you like to say and what you want to not to say, meaning also on the patient, because you may give some characteristics of the patient. I think that this is a very interesting area that may change a little bit the applications for chatbots. So I think that it's just a very interesting and futuristic area of research. And changing the subject, because I know it's different from country to country, but I know that in the US, medical complaints are pretty, are more often, because that's why you give more attention to informed consent and such things, because you have much more complaints than probably in other countries. So do you think that giving a good informed consent, being very specific, may improve or may lower the number of complaints, or you think it has no impact?
It's hard to say, but I think that overall, the idea of patients recording consultations and holding physicians accountable for what's said during the consultation is an emerging trend in the US and elsewhere. There have been studies looking at how often patients record or request to record consultations. And I guess they did a survey of oncologists, and 75% of them said that they have allowed patients to record consultations. And you can look at that with one of two lenses. One lens is that by recording the consultation, it memorializes what was said. So if you omitted something, and probably not ideal. And but from the other side, it will also enforce that what you did say, the patient was able to comprehend. My attitude about this whole body of work is that we need to focus more on ensuring the quality of what we say to patients. And I didn't do this to try and alleviate medical legal concerns. I did it to try and improve how patients are informed, and to really augment the ability to do shared decision making. And I think if there were more scrutiny or auditing of what doctors say, there'd probably be better information given to patients. And look, I'm a urologist. I don't want anybody looking over my shoulder when I talk to patients or do that. I like to, have my own style. But at the same time, I think it's so important what we say to patients, that it's an aspect of care and an aspect of surgical care that probably now can be analyzed and monitored, and we can probably do a better job. And it's going to take feedback. It's going to take time and effort. But I think it's worth it, even for the purpose of just giving the patient the information that they should have to know what they're getting into.
Well, I agree. I completely agree with you. And do you think it doesn't happen often to have patients that are really that have like a very low level of education, and maybe such patients are not able to really understand what you're talking about to change your way, or does it happen? Because I believe, especially where you live, you may have a lot of different cultures that may not be as informed, that maybe that would be very difficult to understand what you're saying. What's your opinion on this?
Yeah, I think that you do have to tailor the way that you deliver your message to different patients because of their interest in hearing more detail or less detail. That said, I think that some of the assumptions that we make about patients who are uneducated may be counterintuitive. I'll give you an example. Patients with low numeracy are more apt to misinterpret generalizations of risk than patients with high numeracy. So for example, if I tell a patient with low numeracy that the risk of erectile dysfunction is low, in their head, their ability to match that up with like what is low is worse than a patient with high numeracy. So a lot of the shared decision-making literature suggests that in patients with low numeracy, you need to make an even more dedicated effort to make sure they understand like just the generalities of like, here's the risk. How would you do that? You might do it with like a visual decision aid where you have like 100-man figure and say like, well, here's the risk of this and here's the risk of that. Now, would you do that for every side effect? No. But if that patient were considering surgery, maybe you could do that for ED and incontinence and take the time to do it. So I know that, most doctors don't take the time to do all that stuff, but in research, we try and think about what should be and what should be ideal. And that's what we're envisioning.
I agree with you, but I mean, in different countries, I've been a fellowship in different countries, and really in a public system, sometimes the time for consultation may be more than 10 minutes. So
Yeah.
I think that you're opening a gap in the management of patients. Very often, it's just some leaflets that are just given to the patient so that you at least your consciousness is okay. So I gave it to him, and that's okay. But I really believe that spending a lot of time with the patient may improve overall the outcomes of the surgery. I mean, patients who are well informed just probably take the side effects easier than those who don't know, or who really just it was not given the ideal priority to the information. So what are the gaps in the literature in this subject? What do you think there are, or if there are gaps actually?
I mean, I think you provided a great segue in that, I think that the link between the amount of information given and outcomes is not well determined. So by giving patients more information, does it decrease their decisional treatment regret? If for patients who undergo surgery or radiation, do they have less incidents of treatment regret afterwards if they're better informed of the risks? My guess would be yes. But even aside from that, I think the concept of giving patients the right information has intrinsic value even outside of some other outcome that's related to it. Like, even if giving information to patients doesn't improve rates of overtreatment or even decisional regret, I think it's sort of a moral imperative to give them this information, if they're embarking on a treatment that has risks. So it's almost like, what are the gaps? How does improving communication affect outcomes? And I think that would be the gap that we want to address and know. And the first step to that is characterizing what is the variation in communication, and then educating physicians on it and seeing if that process of improving their communication through education improves treatment regret or decision-making outcomes.
It's very interesting because the literature is just moving through patient-reported outcomes. If you go to the literature now, all the outcomes are patient-reported, and it's no and the whole urology world is just leaving aside ED, UI, because actually there are some patients that have big incontinence and are happy because they were thinking that they're more focused on their cancer. And there are others that even with one pad are poorly happy. So maybe those patients with better information and with radiation therapy would have been happier than the other ones. So I really believe that we are moving towards a more personalized medicine, a target medicine, and probably this will complicate things because it will be very difficult to analyze big cohorts. Big data won't be possible because we can't compare patients with different social contexts, with different expectations. But I really believe that this particular paper goes right into a hot topic of the moment and opens new research ideas instead of focusing on how many pads and if you do it and if you do the anastomosis one way or the other or whatever. That's not important for the patient. It's like for functional urology. Patients are not more impressed of having 40, 30, or 25 for Qmax. They want to have. They want to be happy and to have a good quality of life. So
yeah,
what is really next for you? Because you told me that it's your area, so you will develop something more. So what is next?
Yeah, I mean, I think that we touched on this a little bit earlier, but what's next for this research? It's so exciting to be a part of communication research right now because it just exploded with large language models and ChatGPT. The idea of being able to analyze textual information has gone from being laborious to being possible on a patient-by-patient basis. So, when this research was conducted in the context of a NIH-funded K08 project, there's 5 years of funding from the federal government in the US. And it took a long time to accrue the patients, a long time to do the coding for this, because it was all done manually. Human beings went through the transcripts and coded exactly how this was communicated. Now that we have this hierarchy and we know what physicians do in practice, we can have computers do this for us. So this is opening a can of worms of, this information that we communicate to patients is now analyzable. And what's new? What's next? It's operationalizing this and seeing how we can, use the new techniques that we have in technologies to leverage that to the betterment of the patient.
Yeah, I truly agree with you because probably we need some standards to report because we all know how to do a logistic regression analysis, but when we're talking about psychology, when we're talking about what's said, how is it said, and as you said, with the new technologies, we will also know maybe if a certain tone is better than the other, because with all these AI technologies, the AI is able to understand if the tone was well perceived or bad perceived, or if that tone is related to a worse outcome because the patient is afraid or is not able to talk, even to record the minutes that the patient is able to talk during consultations. But as you said,
Right.
now you just put it into the ChatGPT or the NLP, and he just analyze whatever you ask him for in a very easy way. Because what really changed is that before all these things were were affordable, but you needed like a PhD in maths or in programming or in informatics. Now you just use your own language, and it's just, it's just democratizing the math and the technology. And as urologists, normally we don't have all these
Yeah.
assets to evaluate. So I really thank you for this amazing conversation. I think really we went through all the different aspects, and I'm happy to put this on the YouTube platform to just to see how good we do with different residents, because actually what's next is to try to do a live podcast with different students, residents, and
Great.
that may be exciting. So I leave you the last words to finish the podcast.
Sure. Yeah, I mean, I think the takeaway from this study is that, we as doctors counseling patients with prostate cancer need to pay as much attention to what we say in clinic as to what we do in the OR. And the precision and effort that we take to be surgeons in the OR, we apply that level of scrutiny to what we say in the patients in the clinic, and we can improve care. I think that doctors are not trained on how to communicate risk well, and that's really exemplified in this article that examines current standard of care. And ideally, in my mind, when you counsel a patient about the different treatment options, you have to go in there knowing that you're going to cover the main side effects of every treatment and try and both mention the side effect, articulate what it means, and then give some overall sense of risk. And ideally, that should be quantified, although as we discussed, sometimes you have to tailor it based on the patient's needs or preferences. And I think by better informing patients of their risks, they're going to be happier on the other end with their treatment decisions. And as we discussed earlier, it may even affect their perceived, patient-reported outcomes. So look forward to seeing where the science goes in the future. And thank you again for having me.
Well, thank you very much. This was episode 6, and thank you for all the audience.